That sudden gut-wrenching pain that just floors. You imagine that hitting with full force, but specifically in a young male, right where it really counts.
Uh-huh.
That's the urgent scenario we're diving into today, testicular torsion.
Absolutely critical to recognize. Testicular torsion is essentially a twisting of the spermatic cord.
The supply line.
Exactly. Think of the spermatic cord as that vital supply line. When it twists, that blood flow to the testicle is choked off. Time here is absolutely the essence.
Okay, so this vital supply line gets twisted. What's the immediate problem with that, and why the massive rush against the clock?
Well, the twisting action directly obstructs the testicular blood vessels. This leads straight to ischemia, a severe lack of oxygen and nutrients getting to the testicle.
Right.
Now, the cells responsible for sperm production, the germ cells, they are incredibly sensitive to this lack of blood supply.
Uh-huh.
So without swift intervention to restore that flow, we risk irreversible damage and, well, the potential loss of the testicle itself.
Right, a real need for speed to get the blood flowing again. We've delved into a clinical review for this deep dive.
Mm-hmm.
Our goal is to give you a really clear, high-yield understanding of testicular torsion, covering everything from the basics to the potential consequences of delay. Think of this as your rapid-fire revision session.
Exactly. We'll break down the key elements and hopefully give you some mental shortcuts, memory aids, to remember the essentials for the MSRA. So let's get right to it. What exactly is testicular torsion?
Well, like we've said, the definition is pretty direct. It's the spermatic cord twisting, and this unfortunate twist leads to a blockage of those testicular blood vessels.
Simple as that, but devastating.
Yeah, and the key point, which we really can't stress enough, is the urgent need to resolve this to prevent that ischemia and potential loss of the testicle. Those little sperm-making factories are just so vulnerable.
Precisely. And to grasp why this twisting happens, we need to look at the etiology, the underlying causes.
Okay.
There are two main types of testicular torsion to keep in mind: intravaginal and extravaginal.
Intravaginal and extravaginal sounds like we're exploring different compartments. What distinguishes them?
Yeah. So intravaginal torsion is the more common type, particularly in older boys and adolescents.
Yeah.
It happens because of an unusual way the testicle is secured within the tunica vaginalis.
The little pouch.
That's the one. Think of the tunica vaginalis as that little pouch inside the scrotum surrounding the testicle. Normally, the testicle has some anchoring within this pouch, but in intravaginal torsion, there's an abnormal attachment, specifically on the posterior lateral side.
Okay.
This loose fixation basically allows the testicle to rotate freely within the tunica.
Ah, so it's like a swing that's not properly attached at the bottom. This free movement leads to the twist.
Exactly that. And a major predisposing factor here is the bell clapper deformity.
Right, I've heard of that.
Yeah, picture a clapper inside a bell. If it's not fixed at the bottom, it can swing around and twist really easily. In this case, the testicle isn't properly anchored within the tunica vaginalis.
Right.
And this bell clapper deformity is often bilateral, affecting both testicles, and it's actually present in about 12% of males.
12%. So a notable portion of the male population has this anatomical setup. What about extravaginal torsion then?
Right. Extravaginal torsion is seen more frequently in newborns. It occurs either while the baby is still in the womb or shortly after birth, basically before the testicle is fully descended and become properly fixed within the scrotum.
Ah, so earlier on.
Much earlier. And here, it's the entire unit, the testicle and the tunica vaginalis together, that twists above where it would normally be anchored.
Different timing, different level of twisting. Makes sense. And our notes mention genetics possibly playing a role.
Yes, although the anatomical factors like the bell clapper deformity are primary, there's some indication that genetic factors might contribute in certain cases.
How so?
Well, perhaps by influencing the development of these anatomical variations, or maybe affecting the strength of the supporting tissues. It's still an area of ongoing research, really.
Okay, so we understand the what and the why. Now, who's most susceptible? Let's talk risk factors. Who's more likely to actually experience this?
The risk factors line up pretty closely with the causes, as you'd expect. For intravaginal torsion, the main risk factor is definitely that bell clapper deformity.
Right.
And it's crucial to remember that because it's often bilateral, if one side twists, the other side is also at increased risk. You have to check both.
Good point. And for newborns.
For extravaginal torsion in newborns, the primary risk factor is simply the incomplete descent and fixation of the testicle at that very early stage of development.
Okay.
And as we just discussed, there's that potential for a genetic component lurking in the background for some individuals too.
So bell clapper means higher risk for older individuals, and incomplete descent means higher risk for newborns.
Got it.
Now, let's get into the mechanics of what's actually happening in the body during torsion, the pathophysiology. What's the sequence of events?
The pathophysiology is pretty straightforward, but really damaging. First, the spermatic cord twists. This twisting then leads to the occlusion, the blockage, of the blood vessels within that cord, mainly the arteries bringing oxygen-rich blood in and the veins carrying deoxygenated blood out.
Right, cuts off the supply and drainage.
Exactly. This blockage results in ischemia, a critical shortage of blood supply to the testicle. And if this lack of blood flow persists, it can lead to irreversible damage and ultimately the loss of the testicle.
So quick summary.
Think twist, block, no flow, potential loss.
Twist, block, no flow, potential loss, concise, and yeah, pretty concerning. Now, if a patient presents with sudden testicular pain, how do clinicians figure out if it's torsion or something else? What are the key things they need to consider in the differential diagnosis?
That's a really vital question. Sudden testicular pain can have several causes, so a careful evaluation is absolutely key.
What else is on the list?
Well, important differential diagnoses include torsion of a testicular or epididymal appendage. These are small bits of leftover tissue from development that can also twist and cause pain, though usually it's less severe than a full torsion.
Okay, appendage torsion. What else?
Then there's epididymitis, orchitis, and epididymoorchitis, which are basically inflammations or infections of the epididymis, the testicle, or both.
Right, infections.
A hydrocele, which is a collection of fluid around the testicle, can sometimes cause discomfort. An incarcerated hernia, where part of the intestine gets trapped down in the groin, can also present with testicular pain.
Okay, hernia too. Less common things.
Less commonly, a testicular tumor might cause sudden pain, maybe due to bleeding or tissue death within it. And finally, mumps, while we mostly think of swollen salivary glands, it can sometimes cause inflammation of the testicles, called orchitis.
That's quite a range of possibilities. So how common is testicular torsion, actually? Let's look at the epidemiology, who gets affected and how often.
Okay. In the UK, testicular torsion is most common in the adolescent years, usually between 12 and 18, with a definite peak around 13 to 16 years old.
Teenagers mainly, then.
Primarily. In the U.S., the annual incidence is about 1 in 4,000 males under the age of 25.
So not super common, but definitely not rare.
Exactly. Looking at data from England back in 2013-14, there were over 3,300 reported episodes of torsion, and the majority, about 2,500, were in children.
And trauma. Does that cause it often?
Interestingly, no. Trauma only accounts for a relatively small fraction of cases, maybe around 4 to 8%. It usually happens spontaneously.
Okay.
And it's also worth noting that some individuals report a history of sudden, severe testicular pain that then resolved on its own.
Really? Like it untwisted itself?
Potentially, yeah. This suggests something called intermittent torsion, a sort of on-again, off-again twisting. That history is really important.
So while not the most frequent condition, it's certainly something you need to be aware of, especially in teenagers. And the low trauma rate just emphasizes that it can happen completely out of the blue.
Absolutely.
Now, what are the telltale signs? What will a patient typically present with the clinical features that should really raise suspicion?
The clinical features are crucial for suspecting torsion. In terms of what the patient tells you of the history, the absolute key is a sudden onset of severe pain in one testicle.
Sudden and severe.
Yes. Younger boys might also complain of pain in their lower abdomen, which can sometimes confuse the picture a bit.
Right, referred pain.
Exactly. Often, this pain can be linked to physical activity, maybe sport, though it certainly can occur at rest or even wake someone from sleep.
Okay.
It's vital to ask about any prior episodes of similar pain, because that could point towards that intermittent torsion we mentioned.
Makes sense.
Patients may also feel nauseous and might actually vomit because the pain is just so intense.
Nausea and vomiting too, wow.
Yeah. And like we said, that history of recurrent severe pain that resolves spontaneously is a really strong indicator of intermittent torsion.
Okay, so sudden, severe pain, maybe after exercise, maybe with abdominal pain and feeling sick, and definitely ask about past episodes. What about what you might find on physical examination? What are the key signs a doctor would look for?
Right, the exam. The scrotal skin on the affected side might look red, inflamed. The testicle itself will likely be swollen and exquisitely tender to touch, like really painful. And it might be noticeably pulled upwards in the scrotum, a bit higher than the other side.
Retracted.
Yes, retracted upwards. A classic finding, though not always present, is increased pain when you gently lift the affected testes. We often talk about pre-and sign being negative in torsion.
Meaning lifting it doesn't help.
Exactly. Lifting the testes doesn't lessen the pain, which can sometimes help differentiate it from epididymitis, where elevation might actually provide some relief.
Ah, okay. What else?
The epididymis, which normally sits behind the testicle, might be felt in an abnormal position, maybe rotated around to the front. The testicle itself might be lying horizontally to bell clapper position rather than its usual vertical orientation.
Isn't that a horizontal lie?
Yes,
Okay.
but a really, really critical sign is the absence of the cremasteric reflex.
Ah, you mentioned that. Tell us more.
So normally, if you gently stroke the inner thigh, it causes the testicle on that same side to reflexively pull upwards. This reflex pathway involves nerves that run through the spermatic cord. In testicular torsion, that reflex is usually absent because the twisting compromises the nerve function or the muscle itself. Its absence is a very strong pointer towards torsion.
So lack of that reflex is a big red flag.
A very big red flag. And finally, just quickly, in prenatal torsion, which happens before birth, at delivery, you might feel a firm, hard mass in the scrotum that doesn't let light pass through it, non-transilluminable, and the scrotal skin might seem fixed or stuck down.
Okay. So the key exam findings: high riding, tender testes, maybe horizontal lie, and crucially, absent cremasteric reflex.
You got to remember, sudden severe pain plus an absent cremasteric reflex equals very high suspicion for torsion. Needs urgent action.
Absent cremasteric reflex, that sounds like a really key indicator. So if torsion is suspected based on these clinical features, what's the next step? What investigations are typically done?
Well, the primary imaging tool used to assess suspected testicular torsion is the Doppler ultrasound.
Right, the ultrasound. How does that help?
It uses sound waves to evaluate the blood flow to the testicles. While its accuracy in picking up torsion, the sensitivity can vary a bit, its ability to correctly identify when torsion is not present, its specificity is generally quite high.
Okay.
It also has pretty good positive and negative predictive values, meaning the results are usually quite reliable in experienced hands.
Are there specific signs on the ultrasound?
Yes, a specific finding known as the whirlpool sign, where you can actually see the twisted spermatic cord swirling, is very suggestive of torsion, highly specific. Ultrasound can definitely be helpful in avoiding unnecessary surgery for other causes of scrotal pain, like epididymitis.
That sounds like a useful tool then. So if the ultrasound shows no blood flow or that whirlpool sign, it basically confirms torsion.
Well, it's not always completely definitive. Ultrasound results can really depend on the skill of the person performing the scan, the sonographer.
Operator dependent.
Very much so. It can also be technically tricky in very young children, prepubertal boys. And importantly, in the very early stages of torsion, maybe just an hour or two in, or in cases where the twisting isn't complete, what we call partial torsion, there might still be some blood flow detected on the Doppler.
Ah, so that could be misleading.
It could be, yes.
Yeah.
So the presence of some arterial flow doesn't entirely rule out torsion, especially if the clinical picture is highly suspicious. You have to consider everything together.
So ultrasound is helpful, but not a perfect yes or no test, especially early on or if it's partial. What do the guidelines in the UK say about using investigations in these cases? This seems critical.
It is, and the UK guidelines, specifically from the Royal College of Surgeons, actually advise against routinely performing imaging studies like ultrasound in patients where the history and physical examination strongly suggest testicular torsion.
Really? Why is that?
The rationale is simple: time. Any delay caused by waiting for and performing an ultrasound can prolong the time the testicle is without blood flow, potentially worsening the outcome significantly.
Okay, that makes sense.
The guidelines emphasize that a negative surgical exploration, meaning going to the operating theater and finding no torsion, is far preferable to missing a genuine case of torsion because of delays for imaging. Time is absolutely critical. Explore first is suspicious.
That's a really important point. Every minute counts, and delaying surgery for an ultrasound might do more harm than good in clear-cut cases. So if torsion is suspected clinically, what's the immediate management? What needs to happen right away?
The cornerstone of management is immediate action and referral. As those guidelines stress, all cases of acute testicular pain in boys and young men should be considered torsion until proven otherwise. Assume torsion first.
Right.
Prompt surgical exploration. That means surgery to directly look at the testicle and spermatic cord and potentially correct affair. The torsion should not be delayed for any reason if suspicion is high.
Get them to theater.
Exactly. Immediate referral to an emergency urology or surgical team is essential. While waiting for that transfer or for theater, the patient should receive adequate pain medication, analgesia, and they should not eat or drink anything. Be kept nil by mouth in preparation for possible urgent surgery and anesthesia. Remember the phrase, acute scrotal pain, assume torsion.
So get them to the specialist urgently, manage their pain effectively, and keep them nil by mouth in case they need to go straight to the operating room. What about trying to untwist it without surgery? I seem to recall hearing about manual detorsion.
Yes, that's right. An attempt at manual detorsion can be made, often in the emergency department while waiting for surgery, but it shouldn't delay surgery.
How is it done?
The technique involves trying to gently rotate the affected testicle outwards, away from the midline. Think of it like opening a book. You turn the page outwards.
Okay, rotate outward.
Usually outwards, yes. Most torsions twist inwards. So you rotate outwards unless doing so makes the pain significantly worse or you feel definite resistance.
And if it works.
If manual detorsion is successful, the patient will typically experience quite dramatic relief of their symptoms, and the examination findings, the position, the tenderness might start to return towards normal.
So that fixes it.
No, and this is critical. Even if manual detorsion appears successful, urgent surgical treatment with bilateral orchiopexy is still absolutely necessary.
Why is that?
Because the underlying problem, often the bell-clapter deformity, is still there. The torsion could easily recur, so surgery is needed to untwist it fully if needed, confirm viability, and then fix both testicles orchidopexy to the scrotal wall to prevent any future twisting on either side.
Okay, so manual detorsion might buy some critical time and relieve pain, but it's definitely not the final solution. Surgery is always needed.
Always. Think of manual detorsion as a potential temporary fix, maybe improving blood flow slightly while awaiting theater, but surgery is the definitive treatment.
Right. Now, we've heard so much about the time-sensitive nature of this. How critical is the timing for saving the testicle? What are the crucial time windows we need to remember?
Timing is absolutely fundamentally critical in testicular torsion.
Yeah.
The likelihood of saving the testicle, the salvage rate, is directly related to how quickly that blood flow is restored after the onset of pain. The duration of ischemia is key, as is the degree of twisting how many turns.
Okay, so give us the numbers.
If the torsion's corrected surgically within 6 hours of the pain starting, the salvage rates are excellent, around 90 to 100%.
Within 6 hours, 90 to 100%? That's good.
Very good. However, if the delay extends out to 12 to 24 hours, the salvage rate drops dramatically down to about 10%, maybe 20% in some studies, but still very low.
Wow, that's a huge drop.
It is. And beyond 24 hours, the chances of saving the testicle are unfortunately very low indeed. Irreversible damage is usually occurred by then.
So that golden 6-hour window is absolutely vital.
It really is. That's the time frame to aim for the best possible outcome. There are some studies showing worse outcomes in certain demographics too, like African Americans and younger males, potentially due to delays in presentation or diagnosis, which is something to be aware of.
Okay. So during the surgical exploration, what determines whether the surgeon tries to save the testicle or ends up having to remove it?
Well, if surgery is performed within that critical time frame, say the first 6-12 hours, the surgeon will untwist the spermatic cord and then carefully assess the viability of the testicle. They'll look at the color, see if it pinks up, maybe check for bleeding from a small cut.
See if it's still alive, basically.
Essentially, yes. If the testicle appears healthy and viable and blood flow clearly returns after untwisting, it will then be surgically fixed. That's the orchidopexy to the scrotal wall to prevent it twisting again.
And the other side.
Critically, yes, the other unaffected testicle should also be fixed during the same operation. That's because the underlying risk factor, like the bell-clapper deformity, is often present on both sides. You have to prevent torsion on the other side too.
Right, prophylactic fixation. What if the testicle doesn't look viable?
If the torsion has been present for a prolonged period, usually beyond 24 hours, or if even after untwisting the testicle looks clearly dead black, no blood flow, then it's not viable. In such cases, the surgeon will usually perform an orchidectomy, which is removal of the non-viable testicle.
Yeah, remove it.
To prevent complications like infection, chronic pain, and potentially some debate about autoimmune effects on the remaining testicle, although that's complex, sometimes removing the dead tissue is the best long-term strategy.
That makes sense. Sometimes removing irreversibly damaged tissue is the necessary course. So if the torsion is corrected in time, what's the long-term outlook for these patients? What's the prognosis like?
If the torsion is corrected promptly, especially within that golden 6-hour window, the prognosis is generally very good. There's a high likelihood of testicular salvage and preservation of normal function,
Hmm.
both hormonal and fertility-wise, although we'll touch on fertility risks later.
Okay.
It's important, though, to be aware of the potential psychological impact, particularly if a testicle has been removed. Body image can be affected. If a testicular prosthesis is desired for cosmetic reasons, its insertion is usually delayed for about 6 months to allow everything to heal properly first.
Okay. And recurrence.
We must emphasize again, if a patient has the underlying anatomical predisposition, like the Bill Clapper testes, and doesn't undergo that bilateral organopexy, the risk of the torsion happening again, either on the same side or the other side, is very high. Fixation is key.
Got it. What about that intermittent torsion?
Right, and even in cases of chronic intermittent torsion, those recurrent episodes that resolve, if they aren't addressed surgically with orchidopexy, there's a risk of long-term damage, like testicular segmental ischemia or atrophy, due to those repeated hits of reduced blood flow. So even intermittent torsion needs fixing.
Okay. So timely surgery is really key for a good long-term outcome and definitely for preventing recurrence. What are some of the potential complications that can arise from testicular torsion, especially if it's not treated quickly or effectively?
Yet, unfortunately, if testicular torsion goes untreated or treatment is significantly delayed, the consequences can be quite serious. These include infarction tissue death due to lack of blood supply.
Right, the testicle dies.
Yes. Also, testicular atrophy, where the testicle shrinks over time even if salvaged, infection developing in the damaged tissue, and potentially permanent deformity of the scrotum.
Okay. What about fertility? That's often a big concern.
It absolutely is.
Mm.
Even with timely detorsion and salvage of the testicle, there's a significant risk of subfertility later in life. Studies report this in around 36 to 39% of cases.
That high,
Yeah.
even if the testicle is saved?
Yes. The reasons aren't fully understood. It might be damage to the sperm-producing cells even from temporary ischemia or perhaps some immune response. And testicular atrophy, that shrinkage, can occur in up to 50% of cases, even after successful and timely intervention, which can also impact function.
Wow, 50% atrophy risk.
It's significant. And unfortunately, even if the testicle looks okay initially and is saved, semen analysis later on may remain abnormal in some individuals, contributing to that subfertility risk.
Yeah.
So follow-up regarding fertility and hormonal function is often recommended.
Okay.
However, and it's important to end on this early intervention, significantly improves the chances of preserving fertility compared to delayed treatment. The quicker you act, the better the odds for everything, including future fertility.
So while prompt treatment offers the best chance by far, delays can lead to really significant and lasting problems, especially concerning fertility and the viability of the testicle itself. This really just underscores the critical nature of early recognition and immediate medical attention.
Absolutely. The key message, the take-home point from all of this has to be that testicular torsion is a true surgical emergency. Rapid diagnosis, based mainly on clinical suspicion, and immediate surgical intervention are absolutely paramount.
And that critical 6-hour window.
That critical 6-hour window is the key to maximizing the chances of a good outcome, saving the testicle and preserving function.
It's really striking how that urgency and time sensitivity just dictates the entire approach in this condition, isn't it? It definitely highlights the importance for everyone, clinicians and the public, to recognize those key clinical signs. Sudden, severe testicular pain, especially in young males, is something that needs immediate, urgent attention. No waiting around.
Precisely. Recognizing those signs promptly and acting fast can make all the difference in the world for that patient's future.
Well, this has been incredibly informative. If you listening want to delve into more essential topics like this to really help you nail your MSRA, make sure to check out PassTheMSRA.com. They have a wealth of resources, question banks, mock exams, the lot.
They really do. And for even more free content, tips, and learning materials, you should also head over to FreeMSRA.com.
Great stuff. Both fantastic resources to support your revision.
Definitely worth checking out.
Thanks so much for joining us for this deep dive into testicular torsion. We really hope this has been a helpful revision session for you.
Hope it helps solidify those key points.
Until next time.